This is our journal clubs and session that we're holding in association with the Paudi Forum. And for today, we have Dr. Sumaya Sendosa as our presenter. She did her MDS training at Dow Dental College under Professor Arshad Hassan's care. And once Dr. Sumaya is done with the presentation, we will have a critical appointment by our team of senior professors, Dr. Yaud Ali Abdi and Dr. Farhan Raza Khan. Everybody else will also get a chance to ask their questions and critique following Dr. Farhan Raza Khan and Dr. Yaud Ali Abdi's comments. So without any further ado, I would like Dr. Sumaya to go on ahead with her presentation and critique this journal club article. So Dr.
Yes, sorry. Window जो है वो मेरी minimize हो गई थी. Am I audible now?
Yes, you're perfectly audible.
Okay. Should I start?
Can you share your screen?
Is my screen visible to everyone?
Initially it was visible, but now it's not.
Let me check. Is it visible now?
Now
Yes,
it's
we can see your screen.
Okay. Assalamu alaikum. Today the article of our discussion is clinical efficacy of sealer-based obturation using calcium silicate sealers, a randomized clinical trial. This article was published in Journal of Endodontics in February 2022. As we know that the quality of root fillings, that is the obturation, is a significant factor in the success rate of root canal treatment. And a number of endodontic sealers and filling techniques have been used and assessed in research studies. And so far, warm vertical compaction with resin-based sealer has been termed as the gold standard technique. Another technique, the sealer-based obturation or single cone technique, which is less technique sensitive and requires less equipment, and it is also easier for the operator. It has been used with different sealers, including calcium silicate sealers, which are hydrophilic and have bioactivity similar to MT. Okay, then there have been few studies regarding the quality of seal-based obturation technique, and few of the studies which have been quoted in the article of our discussion are presented here. One of the studies stated that the filling quality of sealer-based obturation was similar to the continuous wave of condensation technique in the middle and apical third of the roots. On the other hand, another study stated that this technique resulted in more void and irregularly shaped canals. Furthermore, this technique, when combined with conventional sealers, was found to be inferior in quality as compared to the compaction techniques. The calcium sealers have been evaluated in a number of vitro studies, but they have been rarely tested in clinical trials. One retrospective study was conducted using the calcium silicate sealers, in which the endosequence bioceramic sealer was used. This study was published in 2018, but it had some limitations like the retrospective design of the study and the absence of control group. Furthermore, sealer-based obturation technique with calcium silicate sealers have never been compared to traditional compaction techniques in clinical trials. So the objective of this study was to evaluate the clinical efficacy and outcome of sealer-based obturation when used in conjunction with calcium silicate sealers and compare them with continuous wave of compaction technique in combination with a resin-based sealer. So this was a randomized controlled trial, and the study population included patients who were enrolled from the outpatient clinic of the Department of Conservative Dentistry, UNC University, between April and September 2018. Uh, uh, pa- uh, the patients who had fully formed apex and who required root canal therapy were included in this study, along with those who were who were above 18 years of age and in good health. Patients who had communication problems or had teeth which were affected by cracks or periodontal bone loss were excluded from the study. Furthermore, teeth with root canals which were not negotiable within 2 mm of the radiographic apex were also excluded from the study. And patients who presented with moderate and severe pain after the first visit of cleaning and shaping in this study were also not enrolled further in the study. The sample size was calculated using G power 3 software, and a sample size of 50 teeth per group was calculated. In the first visit, local anesthesia was administered, rubber dam isolation was done, access preparation was performed, the working length was determined using apex locator, canal preparation was done with rotary files, and irrigation was performed with sodium hypochlorite. Then in the second visit, the patients were asked about their symptoms, and only those patients who had no or mild pain after the first visit of cleaning and shaping were included in the study, and their consent was recorded to participate in the study. This was followed by generation of computer generated list of random numbers by an assistant who was blinded to the study objectives. The list was concealed, and on the uh, second visit, before the treatment, each participant was provided with an enrollment number and randomly assigned to one of the two groups based on the obturation protocol. Uh, these are the protocols for the two groups of obturation. In the sealer-based technique, the endoseal TCS sealer was used, and it was placed into the middle third of the canal using a 24 gauge needle tip. A single GP cone was inserted into the canal following an up and down motion thrice to allow the sealer to penetrate better. The GP was then cut and compacted. In the continuous wave of condensation, the GP points were coated with the AH plus sealer and inserted into the root canals. A heated plugger, which could penetrate 4 to 5 mm short of the working length, was inserted into the canal, and it was used to cut and compact the master cone. This was followed by the backfill of the canal, which was performed by a thermoplastic injection technique. These are the outcome variables of the study. They assessed post-operative pain and quality of obturation. The post-op pain was assessed using a scale from 0 to 10. Patients were reported to uh, express their pain from 0 to 10. And this scale was further categorized into 4 groups as none, mild, moderate, and severe pain. The quality of obturation was assessed in terms of sealer extrusion and root filling voids, which were defined as absent or present, and the level of root fillings, which was classified as adequate, long, and short. The adequate obturation were those which were till the radiographic apex or within 2 mm of the radiographic apex. The long obturations were termed as those which had extruded from the apex, and uh, the short were those canals which were non-negotiable within 2 mm of the radiographic apex, and they were excluded from the study. Then the final healing outcome was assessed on the basis of radiographic analysis post-operatively and observation of clinical symptoms. The radiographic analysis was performed based on the periapical index scores, And the clinical symptoms such as pain, swelling, sinus tract, and functionality of the tooth were observed. The healing outcome was then categorized as healed, healing, and diseased. And furthermore, success rates were classified based on loose and strict criteria. The loose criteria stated healed and healing cases as successful, and the strict criteria termed only the healed group as the successful as success. The statistical analysis was performed using SAS version 9.2. The outcomes were statistically compared by using chi-square test or fissure exact test according to the variables, followed by multivariate analysis with logistic regression. This is the table presenting distribution of post-operative pain and quality of root canal obturation in both the obturation techniques. As we can see, the results are not significant. These are the success and failure rates. As we can see that more of the necrotic and retreatment cases had the necrotic and retreatment cases had more increased success rate, higher success rate. Then we can see here that sealer extrusion and post-operative pain are significantly reducing the success rate of the root canal treatment performed. The success rate of this study, which is under discussion, were compared with two other studies, one of which was systematic review, which was published in 2007. And the other study was a retrospective cohort, which I also talked about in the introduction, and it was published in 2018. Using the loose criteria, the success rate of the present study was higher than both the systematic review and the retrospective study. Then comparison of success rates of both the obturation techniques was assessed, and the results, although they were insignificant but still promising, we can see that the success rate of continuous wave of compaction was 92.3%, and that of the sealer based obturation was 94.3%. These are insignificant results, but still the success of sealer based obturation was a little higher than that of a continuous wave of compaction. Then the authors have stated that the voids in this study were found to be insignificant to the outcome, which is in agreement with some previous studies. But there was one systematic review which reported significant differences of success rates between teeth with satisfactory and unsatisfactory root fillings. But in this systematic review, the criteria also included inadequate seal along with the presence of voids, which resulted in high heterogeneity of the data. Then sealer extrusion in the present study was found to be a possible predictor of failed cases. And 3 out of 4 failed teeth sealer extrusion had vital pulp without preoperative apical radiolucency. Therefore, the success rate of teeth with sealer extrusion and periapical radiolucency was 94.4%, and that with sealer extrusion and no periapical radiolucency was 62.5%. On the basis of loose criteria. So on the basis of these results, the author concluded that overfilling induced a worse effect in teeth without periapical radiolucency than in those teeth which had periapical radiolucency, and this they associated with the fact that the teeth which have periapical radiolucency, there is already a recruitment of chronic inflammatory cells and an upregulation of inflammatory cytokines, which help in which help in resisting the foreign particles such as extruded sealer. But on the other hand, if we see the other side of the story, there is this reference from Pathways of Pulp, which states that if these activated macrophages are unable to engulf the large foreign particles, may fuse to form giant cells on the surface of the particles and continuously release mediators and cytokines, which can further result in further destruction. Then in this study, patients were asked about their signs and symptoms after the first visit of cleaning and shaping, and only the patients, as we discussed before, only the patients who had mild or no pain were enrolled in this study. This was due to the fact that the authors wanted to standardize the enrolled patient in terms of sensitivity to the pain. The limitations of the study, as mentioned in the study, were the first 3 points. The author stated that postgraduate endodontic residents and one specialist participated in this study, and multiple operators produced different skill and outcome with preferred instrument. Moreover, the study had short follow-up period, an average of 17 months, and sample size calculated was not fulfilled. The second and third point were due to time limitations. Some limitations were not mentioned in the study, but as per my understanding, I have mentioned it. We can have a discussion on this later on. The impact of rotary system use, intracanal dressing if placed, and irrigation technique were not addressed in the study. And furthermore, restorative failure, if any, was also not discussed. So to conclude, within the limitations of this study, it was found that sealer-based obturation using endoseal tricalcium silicate sealers can be a possible alternative to continuous wave of compaction using AH plus sealer. Sealer extrusion and post-operative pain negatively affect the outcome of root canal treatment. Further follow-up and other studies with large sample sizes are needed for better reliability. Thank you.
Thank you, Dr. Sumaya. Very well presented. It's a very recent article and it's a clinical trial. You have selected a very good article for the discussion. Now I will request Dr. Yavar Ali Abdi to basically ask any question that he have from the presenter.
Assalamu alaikum, everyone. First of all, I would like to appreciate Dr. Sumaya for selecting such a recent, very good article and a very good presentation by her as well. First of all, I would like to ask Sumaya, why did you select this article? What was the reason behind that you selected this particular article?
I discussed it with my supervisor and we thought that the methodology was very comprehensive. So that was the prime reason we selected this article.
I see. And as far as the weaknesses of the articles are concerned, the author has already written that the follow-up is pretty short, the sample size is short, and the operators were different. There were PG trainees and the consultants. So that must have created some kind of bias or maybe error in making this research. What is your comment on that?
I think they have already mentioned that the sample was not fulfilled. The calculated sample was not fulfilled, which could affect the power of study somehow. So maybe in future study, probably replicating this methodology can be performed with a better sample size and a longer follow-up period. So like we can have more healed cases because healing outcome increases with increased time of follow-up.
Exactly, because there are different studies in which we can see that healing could take up to 10 years, right? And sometimes we'll see that the healing has occurred and then the lesion came back after 5 years or so. So ideally speaking, one should try to keep the study for longer follow-up cases. There's
Exactly.
one more.
The guidelines have stated at least 4 years, because healing, like they have said that healing takes on like continues till 4 years. So at least 4 year follow-up period, 3 or 4 year period is recommended.
Yeah, exactly. 4 to 5 years is much better. There's one more thing which I found out is in the inclusion, the writer did not mention clearly about the inclusion criteria. And he said the subjects were all older than 18 years of age and in good health. And in bracket, they have written the American Society of Anesthesiologists classification 1 or 2. So ideally speaking, they should have given proper inclusion criteria, or they should have given the proper reference for that as well. So this was a little confusing for me as well. Then, do you want to comment on that?
Yeah, I agree with you.
I see. Then, when they look at the evaluation of obturation, this is again not clearly identified whether a cone indicator was used or they don't mention on the type of the
That
digital
they have not
radiographs they use.
they have not standardized the radiographic method.
Yeah, and naturally there are chances of magnification errors as well. Uh, what do you think? Suppose if they have used CBCT instead of anything, or they may have used but they haven't mentioned it. Do you want to comment on that as well?
Yes, I think if they are using a two-dimensional image, then it should be standardized, like the angulation of the radiographs. And if they are using CBCT, then of course that's always better than a two-dimensional picture.
Yeah, because this is a very recent article, and CBCT is nowadays frequently
Commonly,
easily available, especially in the the university they are coming from. And then there's wide variation of results in strict criteria and loose criteria, which is indicating a loss of information to some extent. Uh, do you agree, or would you like to comment on that as well?
I think that is due to the short follow-up period, because as I discussed, that longer follow-up periods can include more cases which are healed.
Hmm.
So like right
Yeah,
now, the strict criteria might be missing few cases which might heal in near future.
yeah, yeah, maybe you're right. Then there was another issue. The 19 patients failed to follow up in the particular research out of 87 subjects. This is a
Yes,
high dropout ratio.
yes.
They didn't mention any reason for loss of those patients or to follow up. Why did they
They
come back?
haven't yes, and they haven't mentioned any any point regarding covering up those uh, sample also.
Yeah, they
And
should
that
have
could be due
mentioned
to
that as well.
the time limitations, because they were not even able to fulfill the required sample size. So let alone the lost patients.
Exactly. Then they said vital teeth showed more negative outcome in this research. The authors failed to find the reasons for it, as the attributes in the comparison to necrotic and bleed treatment teeth are different. So, would you like to comment on that as well?
Yes, I was reading a systematic review which was mentioned in the reference of this article, and some other studies also. Uh, their results were different from this study. In their studies, the vital cases were more successful, And this study stated otherwise, but I think it could be due to the fact that in some cases they have used ultrasonic irrigation. So maybe they are using irrigation in the necrotic and retreatment cases, because they have mentioned that the cases which had more contaminants, they used PUI, passive ultrasonic irrigation there in those cases. So maybe that could be a reason for the success of these necrotic and retreatment cases.
Mhm. And the tables are confusing, and making interferences was very difficult, as lots of data was not clearly marked. This is what I found out. Maybe if you would like to comment on that as well. Few of the tables.
I think there is
Yeah.
that you want to say?
Yeah, you can say that as well. And then the variables, there are so many variables
Yeah,
they have
very.
checked. And if you look at the research, like for age, maybe you'll find out that less than 50%, more than 50 years of age, you'll find so many different results and variations in different studies. Similarly, as far as the sex, like male, female, success rates are different in different studies, to tie vitality and blah, blah, blah. And another thing which I noticed is, according to American Dental Association's quality of extrusion material, overfilling by more than 2 millimeter past the radiographic apex represents a technical error. So, what is your comment on that?
I agree, because in this study also they had determined the working length using apex locator, and
Yeah,
that should not lead to extrusion of the GP or sealer or the obturation material. So this could be
yeah.
a technical error.
Yeah, but they said the operators were different, the PG trainees and the consultants. So I'm sure that that must be the reason of extrusion, because if you lose the control, then there are chances of damaging the apical constriction.
They
And
have
the
mentioned this as a limitation, but they, in the study where they have
yeah,
mentioned this as a limitation, they have also mentioned a reference of a systematic review which stated otherwise, and it says that the residents and specialists had highest success rates uh, while performing the root canal treatment as compared to other groups. So like they
yeah,
have
true.
sort of defended this point, this limitation.
This limitation, very true. Agree. And there's one more thing. If something is extruded out of the canal and it appears the extruded sealer, right? How would you evaluate that the sealer is completely resolved? Because suppose if the radio opaque element of the sealer is resolved, you won't be able to see unless you see the histological study of that section.
Exactly.
So this is an again a big question mark, because you won't be able to appreciate whether the sealer is there or it has been resolved.
So
So
histological studies are required to
yeah,
support.
exactly. But again, there are so many limitations to go for the histological studies of vital organs. Well, otherwise, you presented very well. And I really appreciate once again that it was a great effort. I congratulate you and Dr. Arshad for supervising you. And that's all. Back to Dr. Robia.
Thank you, Dr. Jawar. You have highlighted a very good conversation and the very good point in the article that were the limitations. And now for the technical aspects or the STARS point of view, I will request Dr. Farhan to basically critique and then question Dr. Somaiya.
Thank you very much. I'm really glad that our clinical trial has been selected this time, because there is a lot of discussion that can take place with an article that has data. So I have noted a couple of points, and I hope people will pay attention to it as we follow the critical appraisal of this paper as we move through. So I have noted a number of observations here. The first and the foremost is the title. The title is not elaborated. it simply shows, it states that clinical efficacy of sealer-based obturation using calcium silicate sealers, a randomized controlled trial. So it does not state that what are the treatment groups, what are the comparison groups. So in essence, they have continuous wave obturation versus a vertically compacted obturation, which they have stated throughout the paper as SBO, like sealer-based obturation. So it means that, but when we go through it, we notice that both groups have sealers. So there is no point naming one group as sealer-based, where in fact both groups have sealers. So ideally, they should have elaborated on the title so that the readers can understand what are the comparison groups to begin with. So that's the first limitation. And then,
but isn't it like in randomized trial we always have a control group? So
yeah, so you can have control group, but the groups have to be stated. For example, a randomized control trial of continuous wave obturation versus a single cone vertically compacted obturation, right? Or you could
right.
have a title such as a randomized control trial of continuous wave with AH sealer versus one vertical gutta-perca with calcium silicate sealers. So that could have been a better title. So a title which describes the comparison group is a better title compared to a vague title, right? So similarly, when they say sealer-based, they have cases where they have placed one gutta-perca versus two gutta-perca and versus three gutta-perca. And the authors, they do not elaborate as on which type of teeth they have used single cone versus two cone versus three cones, right? So there is a subset missing, whether this selection of cone was on the basis of the tooth type or on the basis of retreatment. And when I talk about retreatment, this will create a bias in the study because almost 29–30% of the cases were of retreatment. And when we talk about retreatment, the mechanics is a bit different, right? So ideally, these retreatment cases should have been excluded to begin with. But we can argue that since it's a randomized controlled trial, so with the randomization, these retreatment cases were evenly divided in the two groups, and then we are doing regression analysis. So
Exactly.
the confounding effect of the retreatment is settled, is divided, but it would definitely affect the external validity or the generalizability of the study, because whatever results we are getting, we have to extrapolate those results to a target population of teeth. So it means that ideally retreatment should have been excluded out of the study. But since they have taken it in, then a subset analysis of the retreatment cases would should ideally be should have been there, which are not there. So that's one of the limitations. And then if you notice, the principal diagnosis of the cases are missing. You have like necrotic cases, vital cases, and retreatment. But there is no mention in the paper how many of them were reversible or irreversible pulpitis, how many of them were chronic apical pathosis, abscess, etc., etc. So with respect to the technical principal diagnosis, the paper is vague, does not show any principal diagnosis with respect to the actual clinical situation. And then I noticed that one of the requirement of a trial is to have a baseline comparison of variables. So the table 1 actually shows the outcome data, which is against the convention. For any trial, table 1 has to express the baseline comparison of cases before the allocation to the groups. So the baseline comparison is missing. For example, I don't know what is the mean age of the patient allocated to the continuous wave group versus SBO group. There is no mention of that. So like primary thing like age, there is no mention of mean age and standard deviation. There is no mention of how many males and females were there with respect to the treatment groups, right? So the table 1 is technically missing. The baseline comparison is not there. Similarly, for every randomized controlled trial, a consort flow diagram should be there. So there is no flow diagram. They have just mentioned this thing in the first part of the result, that they started with 90 patients and then they lost to follow up 19 patients and all that. So there are two problems here. Problem number 1, a proper table is missing, which can show how many patients were excluded at what level, a descriptive thing. And number 2, there is a little confusion between patients and teeth. The sample size calculation was based on teeth, but when they start the table or the description in the results, they start with patients. Now, since we know that these 74 teeth belong to 68 patients, so it means that one patient could have contributed to more than one teeth, right?
Yes.
You could have like 2 teeth, 3 teeth. So where is that information that how many patients were contributing more than 1 or 2 teeth in the study? Because that has a significant bearing on the results. With the same token, the logistic regression was not the correct statistical analysis here. The correct statistical analysis would be the generalized estimation equation, the GE analysis. So these are some of the limitations that I've noticed, and I've noticed a number of other things as well. For example, when you look at the table number 2, the biggest problem that I have with table number 2, that it elaborates more on the loose and strict criteria of success and failure. Ideally, this table should have described the comparison between group A and group B. Yeah, the 2 techniques, which is the primary objective of the study. So there is no data on the 2 groups. They have actually data which is consolidated data, combined data, and they have stratified it on the basis of loose and strict criteria. Now, coming back to loose and strict criteria, the loose and strict criteria is based on periapical index. And periapical index is, it's more applicable when we are talking about apical periodontitis, right? Here in our case, we have a number of teeth which were vital, right? So if they were vital, to begin with, they have like periapical index like of 1, right? So then what's the point? Unless our treatment is resulting in more lucencies, creating more lucencies, ending up with more lucencies. So now you go back to table 2 and notice one thing, that it states that 50% of the cases presented with preoperative sensitivity, right? 50% of the cases, like out of 74, 37 teeth had preoperative sensitivity. Now, this is not clear. What kind of sensitivity are we talking about? Thermal, or few people consider mastication sensitivity as sensitivity as well. So if it is thermal, then I have big problem with the numbers stated in this paper, because only 23 teeth, 31% of the cases were vital, and the others were either necrotic or retreat. In any case, there was no pulp. So if 50% of the teeth were sensitive, let's assume thermally sensitive, then it is not technically possible, because only 31% of the teeth had vital pulp to begin with. So either they are talking about mastication sensitivity, or if they are talking about thermal sensitivity, then the data, I'm sorry, it's not going along. The numbers, the maths is not there. So something is wrong. Either they have not mentioned it correctly. Similarly, this preoperative sensitivity variable should have been taken to the multivariate analysis, because for multivariate analysis, they have taken variables of what variables? They have taken these 3 variables: sealer extrusion, vitality, and post-operative pain. So ideally, this preoperative sensitivity should have been the 4th variable that should have been taken to the multivariate analysis. And why I'm saying this? Go back to table 2 and see when we follow the strict criteria. So this preoperative sensitivity again is statistically significant. So it not on the basis of clinical significance, but on the basis of statistical significance, that variable was eligible to be taken to the multivariate analysis. Though the multivariate analysis in this case is faulty, logistic regression is not the test of choice here. A generalized estimation equation is. Similarly, so they agree that this study was underpowered, right? Because the sample size was not achieved. But the conclusion they have made are not correct. Why? Because conclusion, the objective was to compare two groups, right? But in the conclusion is a blanket statement which says that only two variables were kind of important, and which were sealer exclusion and post-operative pain. Why not vitality? Because these three were important, but technically speaking, all three were not significant. When we look at the p-values, all three variables were not significant. So ideally, they should have shown a group-wise comparison between the two study arms, and only then a true comparison could have been, obtained. So this conclusion here is very generic, and it does not answer the study questions and the study objectives, right? And what else I've noticed? Some other things as well, but those are not important. So these are a number of things that I've noticed, which make this study reporting a weak one. So in terms of reporting, they could have done better, right? Especially the analysis part, the reporting part, right? And the treatment of variables part. Because one small thing that I would like to share here is when we go to table 3, it shows odds ratio, right? But in essence, they have taken chi-square, right? For odds ratio, you need to make all variables binary. But here, like vitality was not binary, and similarly, post-operative pain was not binary. So there were multiple categories. So either you have to do two things. Either you take chi-square value and take it to the next level of regression, or you make it dichotomized, convert it towards ratio, and then take it to the next level of analysis. So these things are missing here, right? So these are some of the limitations. I've deliberately not asked question to you because these statistical things were beyond the scope of most of the journal club, but we cannot accept paper on the basis of their face value. So we need to critically look into the methodologies and into the areas that could have been done better, could have been treated better. So these are the critique on my part. So if you want to share anything else, please go ahead. Thank you.
Not exactly. I agree with you that some data has been missing, and they have not focused more on the comparison of various outcomes in terms of the two techniques used.
Thank you, Dr. Farhan, for your technical feedback.
Robi, sorry. I would take another minute because we have just discussed these strengths here, but let's look at some the limitation. But let's look at some strength. So the strengths were it's a randomized controlled trial. They have done sample size calculation. They have done randomization. They have used they have described the methodology of using sealed envelopes. They have described how they generated random number, they used random number table. They have taken ERC approval. They have registered the trial at a registry, which is called PRESS Clinical Research Information System, which is equivalent to our clinicaltrials.gov. And then they have described that they committed to the group allocation after the preparation. So that's for the strength that they described it not only at the time of methodology part, but in the discussion part. And then, so these are the strengths. So we must appreciate the strengths of the paper as well. However, when we look at the limitation part, there were some strong limitations. So thank you.
Thank you, Dr. Farhan. Now we have a hand raised from Dr. Javeria. Dr. Javeria?
मेरी हाथ उठा के थक गई थी तो उन्होंने शायद नीचे कर दिया।
Actually, Dr. Javeria is basically not asking by mistake. So I would request residents to participate in it and then ask any question. And my question from the residents that if you want to conduct any study that must be part of your any future proposal, how would you basically take a start for conducting such a trial? What you have learned from this article? Because Dr. Yawar and Dr. Farhan has very meaningfully, critically appraised the article and then pointed shortcomings and how you can improve the limitation in your future study. Any idea?
Assalamu alaikum, Dr. Rubia. My mic was not unmute.
Okay.
So as we were all discussing the limitation of the study, so one of the limitation of the study, which I think Dr. Sumaiya has mentioned or not, I don't remember, but the rotary systems that were used in the study, it was not mentioned because there is an impact of the type of rotary instrument in apical extrusion. So that can be also one of the limitation of this study.
Exactly.
Yeah. One more thing that AH sear extrusion is basically more creating more symptom as opposed to the calcium based sealer. That is another factor they haven't mentioned it. So a lot of variable they haven't considered throughout the studies. From the resident, the question is that if you want to conduct a randomized controlled trial in future, so what changes you are going to make after reading the study?
I think we can improve the power of study by increasing the sample size and better categorization of the data, improving the inclusion criteria, maybe.
Any questions from the residents?
Can I say something?
Yes, please.
Okay. Because आपने सबसे पूछ लिया, मुझसे भी पूछ ली थोड़ा सा कि डॉक्टर अरशद आपका क्या ख्याल है स्टडी के बारे में? क्योंकि वरना आपको पता ना फिर सैर हजम नहीं होती हमारी।
ये तो मैं कह रही थी इतनी देर से खामोश क्यों?
सर क्लास चल रही है। मैं दरअसल वो मेरा सिस्टम क्रैश हो गया था, कुछ मुझे लगता है कि आपकी तरफ से वायरस आया है मेरे पास। तो फिर मुझे मोबाइल फोन से कनेक्ट होना पड़ा है। सो ओके एनीवेज
हम पे
जी जी ओके सो एक्चुअली सुमैया ने एक पॉइंट इसमें ऐड नहीं किया जो मैंने इन्हें कहा था, मेरे ख्याल से वो घबरा गई, परेशान हो गई इस पॉइंट को ऐड करते हुए। आप लोगों को जान के हैरानी होगी कि इन ऑथर्स ने इंट्रोडक्शन के अंदर रेफरेंस नंबर 4 जो है मिसकोट किया है।
नहीं सर, उसको मैंने एग्जैक्ट स्टडी पे जाके मैंने बैक रेफरेंसिंग की और उसका एग्जैक्ट जो उन्होंने लिखा था ना स्टडी, इस स्टडी में कुछ डिफरेंट तरह से लिखा है, लेकिन मैंने उसको करेक्ट करके और एग्जैक्ट कोट कर दिया।
देखें, some ये कहते हैं कि some authors have suggested that the filling quality of SBO is not superior but rather inferior but rather superior to continuous wave condensation technique, और इस पर उन्होंने रेफरेंस 4 और 7 दिया हुआ है। इसका मतलब ये कहना चाह रहे हैं कि इंफीरियर नहीं बल्कि सुपीरियर है। तो जाहिर है जो स्टडीज कोट हो रही हैं दे शुड टेल दैट जो एसबीओ है वो सुपीरियर है सीडब्ल्यूसी से, ऐसी ही बात है ना
जी, जिस तरह उन्होंने कोट किया।
ठीक है, तो जब आप रेफरेंस नंबर 4 देखते हैं तो रेफरेंस नंबर 4 में आपको ओवरऑल वॉइड्स जो हैं सीडब्ल्यूसी में 3.9% और सिंगल कोन में आपको 6.5% मिलते हैं, और सर्वाइकल थर्ड में आपको सीडब्ल्यूसी में 2.8 और सिंगल कोन में 8% मिलते हैं। इतना बड़ा डिफरेंस है, तो ये किस तरीके से कह सकते हैं, ये तो उल्टा रिजल्ट हो गया ना। और फिर रेफरेंस नंबर 7 में वो लिमिटेशंस के अंदर खुद मान रहे हैं कि पूरी की पूरी स्टडी एक ऐसे रेजिडेंट ने की थी जिसका सिर्फ 1 साल का एक्सपीरियंस था कंटिन्यूअस वेव कंडेंसेशन टेक्निक को यूज करने का, और ये खुद मानते हैं कि टेक्निक सेंसिटिव टेक्निक है। तो अगर इतना बड़ी लिमिटेशन आ गई तो उस बेसिस के ऊपर ये क्लेम करना इनके लिए जायज नहीं है। तो मेरे ख्याल से एक्चुअली आई अंडरस्टैंड दिस कि इतने बड़े जर्नल्स जब रिव्यूअर्स के पास भेजते हैं तो कभी कभार रिव्यूअर्स भी इन चीजों को नहीं देख पाते, इन चीजों को कि रेफरेंसिंग किस तरीके से हुई हुई है। और दूसरी बात जो एक और बात को जिस पे बहस नहीं हुई हमारी, वो पॉइंट ये है कि इन्होंने मोड ऑफ फेलियर्स को डिस्कस नहीं किया, बिकॉज हो सकता है कि जो वाइटल केसेस फेल हुए हैं बहुत ज्यादा, उसमें रेस्टोरेटिव फेलियर्स हुए हों, उसमें कोरोना लीकेजेस हुई हों, जो कि रिजल्ट हुआ हो, इसकी वजह से फिर वाइटल केसेस के अंदर ज्यादा फेलियर्स आए हों, जो कि बहुत ही एक माइंड बॉगलिंग सी चीज है कि 95% प्लस सक्सेस रेट होता है और बिलो 90% यानी कि 80s में सक्सेस रेट होता है रिट्रीटमेंट के केसेस का, इवन 70s में भी होता है कभी कभार डिपेंडिंग ऑन द साइज ऑफ एपिकल लीजन। और यहाँ पर इनको 100% सक्सेस रेट मिल रहा है, क्योंकि ऑफ कोर्स इनका जो है फॉलोअप भी इतना ज्यादा नहीं है। तो ये इस तरीके से भी इसको डिस्कस करना चाहिए। मेरा थोड़ा सा कनेक्शन बीच में लूज हुआ था PAI के ऊपर। फरहान आपने कुछ कहा था, कैन यू प्लीज उसको दोबारा बोल सकते हैं आप, क्या कहा था आपने?
जी मैंने ये कहा था कि PAI की बात कर रहे हैं, लेकिन इधर वाइटल केसेस भी हैं, नेक्रोटिक भी है, रीट्रीटमेंट भी है। तो अगर केस वाइटल है और आप इरिवर्सिबल पल्पाइटिस की वजह से कर रहे हैं तो PAI स्कोर तो वैसे ही लो है, राइट?
हाँ,
तो
इसका मतलब है कि PI स्कोर लो है, और अगर इनके हिसाब से फेल हो रहा है तो PI स्कोर बढ़ गया है। ये तो हैरत की बात है हमारे लिए।
एग्जैक्टली तो इसका मकसद ये है कि वी आर डूइंग मोर हार्म, यानी कि
Exactly.
आपका जो इलाज है उससे फायदा नहीं हो रहा है। और यही वजह है कि अगर आप देखें लूज क्राइटेरिया को और स्ट्रिक्ट क्राइटेरिया को देखें तो पता चलेगा वाइटल केसेस के अंदर 82 या 65% सक्सेस रेट है नेक्रोटिक में, जबकि 100% है इस स्ट्रिक्ट लूज क्राइटेरिया पे। तो ये भी तो हो
बिल्कुल।
सकता है कि जिनके पास 5 रेजिडेंट हैं और एक कंसल्टेंट है, तो सारे जो नेक्रोटिक केसेस भाई ने खुद ले लिए हैं और बाकी वाइटल वाले इधर पकड़ा दिया।
Possible.
इट्स क्वाइट पॉसिबल, इट्स क्वाइट पॉसिबल, इट्स क्वाइट पॉसिबल। बिल्कुल ऐसा ही हुआ होगा। ये रैंडमाइजेशन पेशेंट्स में तो की, लेकिन केसेस ऑपरेटर्स के अंदर नहीं की।
एग्जैक्टली तो स्टैंडर्डाइजेशन एंड कैलिब्रेशन ऑफ द ऑपरेटर्स उस पे भी नहीं है, बात नहीं हुई है। तो लिहाजा ये सब चीजें तो हैं। इस लिहाज से असल में सबसे बड़ा जो प्रॉब्लम है ना, जो रिपोर्टिंग ऑफ द रिजल्ट्स इन टेबल 2 इज नॉट बेस्ड ऑन स्टडी ग्रुप्स, इज बेस्ड ऑन द क्राइटेरिया। तो सिंगल ग्रुप स्टडी होती तब भी लिख सकते थे आप ये लूज और स्ट्रिक्ट क्राइटेरिया। अगर
बिल्कुल
दो
बिल्कुल।
ग्रुप्स हैं तो ग्रुप एलोकेशन के हिसाब से होना चाहिए आउटकम वेरिएबल।
अच्छा,
वो है नहीं, तो दिस इज
एक एथिकल इशू भी है इसके अंदर, जो कि मैंने सुमैया से कहा था ऐड करने को, जो कि वाइटल केसेस को 2 विजिट्स पे ले जाने वाला है। कि आपने क्या किया कि आपने एक वाइटल केस लिया, उसको आप 2 विजिट्स पे लेके गए बगैर किसी जस्टिफिकेशन के, और आपने उसे सेकंड विजिट पे लाके फिर पूछा कि आपने इस स्टडी के अंदर इंक्लूड होना है कि नहीं होना। और फिर जब उस पेशेंट ने आके नहीं मुझे नहीं होना, तो फिर आपने उसे नहीं किया, और फिर आपने उसे अपनी मर्जी से जैसे ही ऑब्जर्वेट करते हैं कि इसको फिनिश करके कर दिया, और उसने अगर होना है तो फिर रैंडमाइज किया आपने। ये काम आप पहले भी कर सकते थे कि अगर उसने नहीं होना स्टडी के अंदर इंक्लूड, तो आप देन एंड देयर उसे ऑब्जर्वेट करके सिंगल विजिट में भी कर सकते थे काम। तो यहाँ पर एक
लेकिन बहरहाल उन्होंने इसका एथिकल अप्रूवल तो लिया हुआ है और ये बताया भी अपने तौर से, जस्टिफिकेशन दी है कि हमने ये काम थोड़ा डिफरेंट किया है कि पेशेंट की इन्वॉल्वमेंट जो है वो उस वक्त किए हैं जब हम कैनाल प्रिपेयर कर चुके थे और साइन और सिम्टम्स बहुत ही माइनर थे या नेग्लिजिबल थे, नहीं थे, तो उस वक्त किया है। तो बहरहाल वो मेथोडोलॉजी का है।
They could have asked for consent before, and then those who were like willing to participate,
Exactly.
उनको फिर 2 visits में।
हाँ कोई हार्म
ये
नहीं,
कर सकते थे,
बल्कि
ये ज्यादा
इनफैक्ट इससे
बेहतर
बेहतर
तरीका
होता कमिट पहले ही हो जाता तो आपको पता चल जाता
एग्जैक्टली।
कि कौन किस तरफ जा रहा है एंड ऑल दैट। तो प्रिपरेशन पे भी जिक्र नहीं किया क्योंकि इसमें तकरीबन 30% डेटा तो रीट्रीटमेंट का है। तो रीट्रीटमेंट में फिर आपकी फाइलिंग भी ज्यादा होगी, आपका टाइम भी ज्यादा होगा, एक्सक्लूजन के इम्कान भी ज्यादा होंगे, थोड़ा एग्रेसिव भी होना पड़ेगा, आप इसमें फिर सॉल्वेंट भी यूज करेंगे, तो एपिकल दाया के बढ़ने के इम्कान भी हैं एंड ऑल दैट। तो उस लिहाज से रीट्रीटमेंट को आइडियली इसका हिस्सा नहीं होना चाहिए था, लेकिन बहरहाल उन्होंने वो जो है वो तीतर और बटेर मिला के किया है।
बहरहाल इस स्टडी की एक सबसे बड़ी स्ट्रेंथ ये है कि जर्नल ऑफ एंडोडोंटिक्स में पब्लिश हुई है।
That is the only strength.
तो सारे खून माफ है इसमें।
सारे खून माफ, बिल्कुल।
We have 3 minutes left. Any
Okay.
student?
रेजिडेंट्स प्लीज। मैं अब चुप हो जाता हूँ।
हाँ,
जी मैं भी।
please hurry up. It's your session.
Okay, I'm Dr. Saqib from Khan University. Thank you, Dr. Somaiya, for such a nice presentation. I have just one question from Dr. Farhan, that if you look at table 3, so they have assigned the necrotic variable as odds ratio of 1. So my question is that how do we decide to which variable have to be neutral one? Like if we give the vital variable of odds ratio of 1, the results then change drastically. So is there
देखिए जब भी आप ये रिग्रेशन एनालिसिस कर रहे होते हैं ना, तो यू हैव टू सेलेक्ट अ कैटेगरी व्हिच इज अ रेफरेंस कैटेगरी, जिससे कंपेयर करेंगे आप, राइट? तो आइडियली होना इस तरह चाहिए जिसमें बेहतर आउटकम आता है। अगर आप उसको ले लेंगे स्टैंडर्ड, तो बाकी चीजों के अंदर आपके जो कॉन्फिडेंस इंटरवल होगा वो अगर प्रोटेक्टिव है तो वो 1 से छोटा आएगा, और अगर वो डिजीज कॉजिंग है तो 1 से ज्यादा आएगा। तो टेक्निकली ये आपकी अपनी अंडरस्टैंडिंग होती है कि आप किसी एक को रखें। इसमें हार्ड एंड फास्ट रूल नहीं है। फॉर एग्जाम्पल कहीं जेंडर में डिफरेंस आ रहा है तो आप मेल या फीमेल किसी एक को भी बना सकते हैं, लेकिन ये आपको अंदाजा होना चाहिए कि आप किस कैटेगरी को बना रहे हैं रेफरेंस। बिकॉज जो रेफरेंस कैटेगरी है, अगर उससे ज्यादा आपको मिल रहा है आउटकम, मतलब 1+ आ रहा है, आपका कॉन्फिडेंस इंटरवल का लोअर बाउंड और अपर बाउंड दोनों 1 से ऊपर है, तो आप कहेंगे दूसरे ग्रुप के अंदर रेफरेंस कैटेगरी से ज्यादा डिजीज देखी गई है। और अगर 1 से नीचे है अपर एंड लोअर बाउंड, तो आप कहेंगे कि जो दूसरा कंपैरिजन ग्रुप है रेफरेंस के मुकाबले में वो प्रोटेक्टिव है, राइट? तो यहाँ पे आपकी मर्जी, आप किसी को भी रख सकते हैं, लेकिन यूजुअली उसको रखा जाता है जिसका आपको पता हो कि ये स्टैंडर्ड है, इसका हमें पता है कैसी होता है। जिसका आप जानना चाहते हैं उसको आप रखते हैं कंपैरिजन ग्रुप में, और जिसका पता होता है उसको आप रखते हैं रेफरेंस में। लेकिन टेक्निकली आप किसी को भी रख सकते हैं, राइट? कोई हार्ड एंड फास्ट वो नहीं है, मना
लेकिन
नहीं है, बस आपको पता होना चाहिए आप क्या कर रहे हैं।
सर, लेकिन अगर हम फर्ज करें चेंज करते हैं, इसमें हम वाइटल टूथ को रेफरेंस ग्रुप रखते हैं, तो फिर रिजल्ट्स चेंज नहीं होंगे सर?
नहीं, तब्दील नहीं होंगे। स्पेशली अगर नॉन सिग्निफिकेंट है तो वो नॉन सिग्निफिकेंट ही रहेगा। लेकिन अगर सिग्निफिकेंट है और आपने तब्दील कर दी कैटेगरीज, तो कहीं वो 1 से ज्यादा आ रहा है, मतलब कहीं वो डिजीज कॉजिंग आ रहा है, और दूसरी तरफ से वो प्रोटेक्टिव आएगा। फॉर एग्जाम्पल मैं आपको मिसाल देता हूँ, आपने ग्रुप बनाए वैक्सीन वर्सेज अनवैक्सीनेटेड, राइट? तो अगर आपने वैक्सीन और ये कहा कि जी किसमें इन्फेक्शन ज्यादा होता है, मतलब कोविड का इन्फेक्शन आप देखना चाह रहे हैं, और आपके पास ग्रुप में वैक्सीनेटेड वर्सेज नॉट वैक्सीनेटेड, तो अगर आपने वैक्सीनेटेड लोगों को बना लिया है अपना रेफरेंस कैटेगरी, और जो बगैर वैक्सीन के लोग हैं उनमें आप देख रहे हैं तो उनमें डिजीज आपकी 1+ नजर आएगी, मतलब उसमें नजर आएगा कि 1.5 से लेके 9.5 है इसका ऑड रेशियो का कॉन्फिडेंस इंटरवल लोअर एंड अपर बाउंड, मतलब उसमें 50% से 950% ज्यादा इम्कान है डिजीज होने का अगर आप वैक्सीन नहीं लगी। अब इक्वेशन को स्विच करें, आप बना लेते हैं कि जी जो अनवैक्सीनेटेड लोग हैं उनको आप बना लेते हैं रेफरेंस कैटेगरी, और वैक्सीन में देखते हैं कि इनमें कोविड हुआ कि नहीं हुआ, तो आप देखेंगे कि अब आपका ऑड्स रेशियो 1 से छोटा हो जाएगा, 0 पॉइंट में चला जाएगा, इसके दोनों अपर एंड लोअर बाउंड, विच मीन्स कि वैक्सीन लाइक इफेक्ट है। ये लोग प्रोटेक्टेड है फ्रॉम द डिजीज। उसमें चीजें 1 से रेसिप्रोकल हो जाएगा ना, यानी कहीं लिखा है 1 और कहीं लिखा है 1 डिवाइड बाय x, तो जब आप 1 से डिवाइड कर देते हैं तो रिवर्स हो जाता है, रेसिप्रोकल हो जाता है।
ओके सर, थैंक यू सो
राइट,
मच।
मतलब मैथमेटिकल फिनोमेना।
थैंक यू सर।
Okay.
Any more question from residents? Otherwise, we conclude this session for today.
हाँ, किसी ने ये पूछा है कि क्या इंटर एग्जामिनर रिलायबिलिटी होनी चाहिए? यस, होनी चाहिए, उसको रिपोर्ट भी करना चाहिए, आइडियली मेंशन होना
इन्होंने
चाहिए।
की हुई है इंटर और इंट्रा एग्जामिनर रिलायबिलिटी, दे हैव मेंशनड
रिलायबिलिटी
इट।
निकाली हुई, ठीक है।
A question, sir. When taking from, I'm Dr. Fazan, I'm an instructor here. Dr. Farhan, I wanted to ask, when taking from univariate, or in this particular case bivariate analysis to multivariable analysis, we usually set a cutoff point of 20% or 0.20 as significant p-value. In this particular case, they did not specify anything of the sort, and I think they resorted to only 5% as their cutoff value, which is why your variable of interest, post-operative sensitivity, was pre-operative sensitivity, was also not included in the multivariable analysis.
तो इस यही होना चाहिए कि आप 10% या 20% रख लेते हैं कट ऑफ, और फिर वहां से लेके जाते हैं, बिकॉज वी नीड एटलीस्ट 3 or 4 वेरिएबल फॉर अ मल्टी लेवल मल्टी वेरिएबल एनालिसिस। तो अब ये यूनिवेरिएट कहते हैं, लेकिन असल में वो बाईवेरिएट ही होता है जिसको यूनिवेरिएट कहा जाता है, क्योंकि असल यूनिवेरिएट तो सिर्फ मीन और स्टैंडर्ड डिविएशन है, राइट? तो आमतौर पे 10 या 20 रखा जाता है, आपको 4 या 5 चाहिए, इससे ज्यादा की जरूरत नहीं है। अगर बहुत ज्यादा वेरिएबल आ रहे हैं तो आप उसको कम करके 10 कर देंगे, बहुत कम आ रहे हैं तो आप उसको 20 कर देंगे। ये आर्बिट्रेरी होता है, इट डिपेंड्स ऑन द रिसर्चर कि वो क्या चाहता है। अगर कहीं कोई भी नहीं आता तब भी आप 2 या 3 लेके जा सकते हैं on the basis of their clinical significance.
Please, sir. Thank you.
Right?
There is a question from Dr. Shaman, I think so. Do we need inter-examiner reliability test between all the researchers?
ये हो गया, अभी डिस्कस हो गया, सुमैया ने बता भी दिया।
डॉक्टर जोजर ने भी सेम बात की है, पोस्ट ऑपरेटिव पेन का एंड देन डायग्नोसिस का। जैनब वाला क्वेश्चन मेरे ख्याल में मोस्ट लाइकली हसन साकिब के क्वेश्चन से आंसर हो गया। No more question, then we are going to conclude the session.
I would like to thank my supervisors, Dr. Arshad and Dr. Javeria, for always guiding me and helping me in this article also.
Thank you, Dr. Sumaya. It was very well presented. Article was very nice, and it was taken from the Journal of Endodontics, and it was a clinical trial. So everybody take a lot of interest to find out the critique and everything. Thank you, Dr. Arshad and Javeria, for supervising her work. Dr. Farhan for taking out time and basically giving detail on the statistics of the article. Dr. Yavar Ali Abadi basically on the basic topic and then critique. Now we are basically moving towards the next session. That is basically after a month. Any volunteer from any institution who want to participate in the next session can email on my email ID or Dr. Faizan email ID. Then we will circulate one week before the actual date. So thank you everyone for joining and participating actively in the session. I will request the resident basically to go through the article at least one day before and take active participation and basically come up with the critique. It's a very good forum for them and they can learn a lot from your seniors like Dr. Farhan. And then you can plan out your future studies from these articles. You can get ideas from your future studies. So actively participate and go through the article at least one day before. Thank you so much, everyone. Dr. Faizan, do you have any screen to share with everyone to basically circulate their article or the case for the next upcoming session?
So we don't have a screen prepared, but we'll share our email addresses with them so that they can email us and let us know if they are willing to participate in this journal club, and we can let them know as soon as possible.
If somebody want to show their any endodontic failure case or retreatment case or any of the trauma case that they have basically treated in their residency, more than welcome. That discussion would be very nice because they can a lot of critique. So I will encourage them to share their basically the complete case, endodontic case, trauma case, any case they have all the complete record. I think this is the time we can say thank you to our technical team from Aga Khan University, Mr. Sharif. Basically, he is always here to help us for all type of these online sessions. Thank you, Mr. Sharif. And here we are basically going to conclude the session for today. Thank you, everyone.
Thank you. Allah Hafiz.
See you next time. Allah Hafiz.